Before this video reaches 60 seconds, I want you to do something. Place 2 fingers gently on the front of your neck, just below the Adam's apple if you are a man, or just below the prominence of the cartilage at the front of your throat if you are a woman. This is where your thyroid gland sits, wrapped around the front and sides of your trachea, your windpipe. Now swallow once. When you swallow, the thyroid moves upward with the trachea, and you may be able to feel it rise briefly under your fingers. Now press gently but firmly with your fingertips across the front and sides of your lower neck. What do you feel? If you feel nothing but soft tissue and the firm cylinder of your trachea, that is one result. If you feel any asymmetry, one side noticeably fuller than the other, if you feel a lump or nodule of any size anywhere in this region, if you feel a diffuse fullness or swelling across the entire front of the lower neck that was not there the last time you paid attention, if the area is tender when you press, or if you feel a gland that seems enlarged enough that swallowing feels slightly impeded, any of those findings deserve your attention, and I am going to tell you exactly what each of them may mean and what to do about each one. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. The thyroid is the most commonly diseased endocrine gland in the human body. Thyroid disorders affect an estimated 200 million people worldwide, and approximately 60% of people with thyroid disease are unaware they have it. The symptoms of thyroid dysfunction are so broad, so easily attributed to aging, stress, or other conditions, that millions of people carry an undiagnosed thyroid problem for years, while the organ continues silently driving fatigue, weight changes, mood disruption, cardiovascular effects, and, in some cases, malignant transformation. Subscribe to Dr. Miller right now and hit that like button. We are building a community of people who examine their own bodies systematically enough to catch what routine appointments often miss. Every subscriber makes this channel more visible to the next person who needs it. Let me tell you about a patient I will call Catherine. She was 57 years old. She had been gaining weight for 2 years, despite no significant change in her diet or activity. She was cold when others were comfortable. She was tired in the mornings despite sleeping adequately. Her hair had been thinning noticeably for 18 months. Her skin had become drier and slightly rougher on her outer arms. Her bowel habits had slowed. She had mentioned these symptoms to her physician at her annual physical. Her physician had ordered a TSH, which is thyroid-stimulating hormone, a standard screening test for thyroid function. The result came back at 3.8. The laboratory reference range listed normal as anything between 0.4 and 4.5. Her result was filed as normal. She was told her thyroid was fine. What her physician had not done was examine her thyroid physically. What I did in the first 2 minutes of her appointment was place my fingers on her neck and ask her to swallow. The thyroid that rose under my fingertips was not normal. The right lobe was approximately twice the size of the left. The entire gland was mildly enlarged, and there was a firm, slightly irregular nodule palpable in the right lobe, measuring approximately 2 centimeters. Catherine had never noticed it. It had been there, growing slowly, unreported and unexamined, while her TSH sat comfortably within the reference range, and her symptoms were attributed to perimenopause and stress. Her ultrasound showed the nodule clearly. It was sent for fine needle aspiration biopsy. The pathology returned papillary thyroid carcinoma, the most common form of thyroid cancer. Caught at this stage, with no lymph node involvement and no distant spread, papillary thyroid carcinoma has a 10-year survival rate above 98% with appropriate treatment. 2 years later, it might not have been caught at this stage. Her thyroid had been telling the story with a palpable finding for an unknown period of time. Her TSH had said nothing useful about it. I am going to explain the thyroid to you completely because it is one of the most important and most misunderstood organs in the body, and because understanding it is what allows you to interpret what you feel when you examine your own neck. The thyroid is a butterfly-shaped gland sitting at the base of the front of your neck. It has 2 lobes, one on each side of the trachea, connected by a bridge of tissue called the isthmus. In a healthy adult, each lobe is roughly the size and shape of a plum cut in half. The gland produces two primary hormones, thyroxine, called T4, and triiodothyronine, called T3. These hormones regulate the metabolic rate of virtually every cell in the body. They govern how quickly cells burn fuel, how fast the heart beats, how efficiently the intestine moves, how aggressively hair follicles grow, how the skin maintains itself, how the brain processes information, and how the body regulates its temperature. When thyroid hormone production is normal, all of these processes run at their calibrated pace. When thyroid hormone falls, hypothyroidism, everything slows. When it rises, hyperthyroidism, everything accelerates. The effects are total body because the target is every cell. The TSH test measures not the thyroid hormone level itself, but the signal the pituitary gland is sending to the thyroid to produce more or less hormone. When thyroid hormone falls, TSH rises, telling the thyroid to produce more. When thyroid hormone rises, TSH falls, telling the thyroid to slow down. The test is the most commonly used screening tool for thyroid function, and it provides genuinely useful information about the hormonal output of the gland. What it does not provide is any information about the physical structure of the gland. A thyroid can have a TSH within the reference range and simultaneously contain a multinodular goiter, a single large nodule, or a malignancy. The hormone output and the physical structure are separate pieces of information that require separate assessments. The reference range of 0.4 to 4.5 for TSH that most laboratories use was established from population studies that included individuals with subclinical thyroid disease, meaning the range includes people who are already in early thyroid dysfunction. Multiple endocrinology researchers have proposed that a more clinically meaningful upper limit of normal for TSH is 2.5, and that levels between 2.5 and 4.5 represent a gray zone where symptoms should be taken seriously and monitoring should be more frequent. Catherine's TSH at 3.8 was in this gray zone by that framework. Her physician used the standard laboratory range. The symptoms that pointed toward thyroid dysfunction were attributed elsewhere. The physical examination that would have found the nodule was never performed. Subscribe to Dr. Miller and hit the like button. The debate over TSH reference ranges and the clinical significance of the gray zone is ongoing in the endocrinology literature. The physical examination of the thyroid is a 2-minute procedure taught in medical school that is increasingly omitted in time-pressured clinical practice. This channel exists to give you the information and the self-examination skills that make you a more informed participant in your own care. Hit subscribe. Every subscriber means the next person with thyroid symptoms gets closer to the full picture. Now, I want to walk you through the specific findings of thyroid self-examination and what each one means clinically, because this is the information that will allow you to have a more precise and useful conversation with your physician. The first finding is a diffuse symmetric enlargement of the gland, meaning both lobes are enlarged equally, and the entire front of the lower neck appears and feels fuller than expected. This pattern is called a goiter, which simply means an enlarged thyroid. The most common cause worldwide is iodine deficiency, which is less common in developed countries with iodized salt, but still occurs in people on restricted diets or those who avoid all salt. In developed countries, the most common causes of a diffuse goiter are Hashimoto's thyroiditis, an autoimmune condition in which the immune system attacks the thyroid tissue and causes inflammation and enlargement, and Graves's disease, another autoimmune condition in which the immune system produces antibodies that stimulate the thyroid to overproduce hormone and enlarge. A diffuse goiter is not a cancer, but it is a finding that requires ultrasound evaluation and blood tests, including thyroid antibodies, to determine the cause and guide management. The second finding is a solitary nodule, a single discrete lump in one lobe of the thyroid. This is the finding that Catherine had. Thyroid nodules are extraordinarily common. Studies using ultrasound to examine randomly selected adults find that approximately half of all people over 50 have at least one thyroid nodule. The vast majority are benign. Colloid cysts, benign adenomas, and focal areas of Hashimoto's thyroiditis all produce palpable nodules. But a meaningful minority, approximately 5 to 15% of nodules evaluated in clinical settings, are malignant. The factors that increase the concern for malignancy in a nodule are a firm or hard texture rather than soft, irregular or fixed to surrounding tissue rather than mobile when you swallow, rapid growth over weeks to months, accompanying hoarseness or difficulty swallowing, and nodules in men who have a higher proportion of malignant nodules than women despite having fewer nodules overall. Any palpable thyroid nodule warrants ultrasound evaluation. The ultrasound will characterize the nodule's size, composition, and features and determine whether biopsy is indicated. The third finding is multiple nodules in both lobes, which is called a multinodular goiter. This is the most common structural abnormality of the thyroid in people over 60. The gland develops multiple areas of irregular growth over years, often producing a lumpy, irregular texture that is palpable on examination. The majority of multinodular goiters are benign, but they still require ultrasound evaluation and periodic monitoring because individual nodules within a multinodular goiter can undergo malignant change over time, and because the enlarged gland can eventually compress the trachea or esophagus, producing symptoms of pressure, difficulty swallowing, or a sensation of something stuck in the throat. The fourth finding is tenderness on palpation. A thyroid that is painful when you press on it is almost never cancer. Thyroid cancer is characteristically painless, which is part of why it goes unnoticed. A tender thyroid is almost always indicating inflammation. The most common cause in people over 50 is subacute thyroiditis, an inflammatory condition triggered by a viral infection in which the thyroid tissue becomes acutely inflamed and tender. It often follows a respiratory illness by several weeks and produces a distinctly painful thyroid combined with temporary hyperthyroidism as the damaged cells release their stored hormone into the bloodstream. This is followed by temporary hypothyroidism as the gland recovers, and in most people, full recovery of normal function within several months. A tender thyroid is not an emergency, but it requires evaluation and monitoring. Now I want to explain the systemic symptoms of thyroid dysfunction in detail, because the physical examination of the neck is only one part of the picture. The symptoms are what bring people to the doctor, and understanding them precisely is what allows you to connect the dots between what you feel in your body and what the gland in your neck may be doing. Hypothyroidism, insufficient thyroid hormone, produces a specific constellation that I want you to be able to recognize. Fatigue that is not relieved by sleep, specifically a heavy, leaden tiredness that is present from the moment of waking. Weight gain that is disproportionate to caloric intake, driven by the slowing of basal metabolic rate. Cold intolerance, specifically feeling cold in environments that others find comfortable or neutral, often with persistently cold hands and feet, regardless of ambient temperature. Constipation from slowing of intestinal motility. Dry, roughened skin, particularly on the outer surface of the arms and lower legs. Hair thinning, particularly at the outer third of the eyebrows, which is one of the more specific signs of hypothyroidism that most people and many physicians overlook. A slightly puffy appearance of the face, particularly around the eyes in the morning. Slowing of cognitive processing, difficulty finding words, reduced mental sharpness. Elevated cholesterol even with an unchanged diet, because thyroid hormone regulates the liver's processing of LDL cholesterol. Depression that does not respond adequately to antidepressants, and in women, heavier or more irregular menstrual periods. Hyperthyroidism, excess thyroid hormone, produces the opposite constellation. Unexplained weight loss despite unchanged or increased appetite. Heat intolerance, feeling hot when others are comfortable, a rapid or irregular heartbeat, palpitations, or a sensation of the heart pounding, tremor of the hands, anxiety, irritability, or a persistent sense of inner agitation, diarrhea or very frequent bowel movements, difficulty sleeping despite fatigue, muscle weakness, particularly in the thighs when climbing stairs, In older adults, hyperthyroidism can present atypically with fatigue and weight loss as the dominant symptoms, without the classic heat intolerance and palpitations, a presentation called apathetic hyperthyroidism that is particularly likely to be missed because it does not fit the textbook picture. Now, I want to give you the complete protocol for thyroid self-examination, because doing it correctly and consistently is what makes it useful. Stand in front of a mirror in good light. Tilt your head back slightly so the front of your neck is extended and accessible. Hold a glass of water. Look at the lower front of your neck in the mirror. Drink a sip of water and watch the area just below the cartilage at the front of your throat as you swallow. A normal thyroid produces no visible bulge during swallowing. Any visible asymmetry, any protrusion that appears during swallowing, any lump that moves upward with the swallowing motion is visible information worth documenting. Now, place the fingertips of both hands on the lower front of your neck, one hand on each side. Feel both lobes simultaneously and compare them. They should feel roughly symmetric. Press gently and systematically from the top of the gland downward, feeling for any irregularity, any firm area, any discrete lump. Then swallow again and feel how the gland moves under your fingers. Document what you find with a photograph of your neck from the front and side, and repeat this examination monthly. Change over time is as important as what you find at any single moment. How old are you? Write it in the comments right now. I want to see the age range of this audience because it directly shapes what I focus on next. If most of you are in your late 50s and 60s, I want to address the specific pattern of Hashimoto's thyroiditis in perimenopausal and postmenopausal women, because the hormonal transition of menopause creates a period of significantly elevated autoimmune thyroid risk that almost nobody discusses with women at that stage. If many of you are in your 70s, I want to address what the evidence says about the appropriate TSH target in older adults, because the clinical guidelines have shifted on this and most patients are still being managed to targets that may not be appropriate for their age. Catherine called me 6 months after her surgery. Her thyroid had been removed. She had received radioactive iodine ablation as is standard for papillary thyroid carcinoma, and she was on thyroid hormone replacement. She was doing well. She told me 2 things that I think about often. The first was that looking back, she had noticed the swelling in her neck in photographs from at least a year before her diagnosis and had simply not recognized it as something to investigate. The second was that the symptoms she had been carrying for 2 years, the weight gain, the cold intolerance, the fatigue, the hair loss, were now resolving on her replacement therapy. They had been thyroid symptoms after all, not perimenopause, not stress, not aging. The gland had been failing for years, quietly, while a number on a blood test stayed within a reference range that did not capture what was actually happening. Your thyroid is accessible. It sits at the surface of your neck, and it can be felt and seen in a way that most internal organs cannot. The information it provides through a 2-minute examination is different from and complementary to the information provided by a blood test. Both are needed. One has been systematically neglected. You now know how to perform the examination. You know what you are looking for, and you know which findings require prompt attention versus monitoring. Put your fingers on your neck. Give it 2 minutes. Your thyroid has been there the whole time, waiting to be read. I am Dr. David Miller, and I have spent 15 years watching thyroid disease be managed at the level of a hormone number while the physical gland went unexamined and the symptoms of dysfunction were attributed to everything except the organ producing them. The thyroid does not hide. It sits at the front of your neck, and it grows and changes in ways that are palpable and visible when someone looks. Subscribe to Dr. Miller, hit the like button. Share this with someone who has been told their thyroid is fine based on a blood test, but who is still experiencing the symptoms I described today. Fine on a blood test and fine as an organ are not always the same statement. The healthcare system profits from managing thyroid dysfunction with ongoing prescriptions once it is diagnosed. I profit from you finding the nodule, making the appointment, and catching it before the conversation becomes about cancer staging. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you feel any lump, asymmetry, or abnormality in your thyroid region, or if you are experiencing symptoms consistent with thyroid dysfunction, please see your physician promptly for examination, ultrasound evaluation, and appropriate blood testing. Do not rely on self-examination alone for diagnosis.